Good morning, Barry. How are you this morning?
Good morning. That's okay. We'll do it in here, and we'll have your computer up, and we'll watch it.
Do you need another chair?
No, we should be okay.
Three,
All
test
right,
1, 2, 3. Hello, Barry. How are you?
Okay.
Hello, Barry. Can you hear me?
They're trying to log on here.
Just
Good morning. Can you hear us over there?
Can you hear me, Barry? I can hear you.
My volume is down low. Can you hear me now?
Hello, Barry Trachtenberg. Are you there?
Yes. Can you hear us?
Yes. Can you hear me?
Yes, I can hear you. Can you hear us okay?
Yes, I can. I'm going to pass the baton on to you to become the presenter. So hang on here for just a minute. And we're going to make presenter. And you are now the presenter and can show your screen. Hello, Joan. Good morning.
Okay, so Eric, you can see our screen now?
I can see your screen. It says case presentation, Paul Karanagis.
Well, excellent pronunciation.
How do you pronounce this?
Morning, sir. I'm Dr. Paul Karagianis. I'm one of the second-year fellows here at Methodist. Morning, you all.
How are you today?
Not too bad. Not too bad. Thank you for inviting me.
Oh, great to have you. Great to have you. Thank you for doing this. We appreciate it so much.
Of course. Are there a few more team members who will be joining our webinar? Or?
Yes, we're waiting for, we usually have to wait a few minutes to get everybody in. So hang on. I'll let you know. Good morning, Jody. How are you?
Good morning. I'm good. How are you?
Good. We're glad to have you here. Good morning, Vaneda. Good morning, Calvert Bush. Good morning, Thelma Rodriguez. Good morning, Joe Carver. Good morning, Chiari.
Morning.
How are you?
I'm good, thanks.
Great. Glad to have you.
Thank you.
Can you hear me?
I can hear you well. Good morning, Dan.
Hey, Eric. How are you?
I'm good. How are you, Dan?
I'm very good, thanks.
Great.
Looks like we have our friends from Houston presenting today.
You've got a very
Yes.
nice gentleman. Paul, you want to introduce yourself to everybody?
Of course. I'm Dr. Paul Kirajan, the second-year fellows here at Houston Methodist, with an interest in cardio-oncology, presenting with Dr. Barry Trent.
Super. Thank you, guys.
I think we can go ahead and proceed on. We will be recording the presentation. You can go ahead and get started, Paul.
Thank you all. I'm presenting the case this morning of one of our patients from earlier this year. Mr. Rent was a 70-year-old male, had a history of chronic atrial fibrillation, type 2 diabetes, hypertension, some mild CKD, and HFpEF, who presented to our advanced heart failure clinic just about a month and a half ago. He'd been followed by a community cardiologist for his atrial fibrillation and heart failure, and had become recently more difficult to manage with worsening heart failure symptoms and some recent presentable symptoms. Just going briefly through his cardiac history. The patient had a diagnosis of atrial fibrillation in 2007. He'd been uneventfully cardioverted at that time with a return to sinus rhythm, and had been in sinus for a good period of time without much issue, but had a reemergence of AFib, and unfortunately failed cardioversion, has been in permanent AFib since 14. His heart failure was diagnosed in 16. His echocardiogram at that time showed severe concentric LVH, but he preserved ejection fraction. And as part of his workup for new onset HFpEF, he'd had a left heart cath that same month with no obstructive artery disease. He initially had fairly well-controlled class 2 symptoms, and looked for all the world like a very typical HFpEF patient that many of us see in clinic themselves. Interestingly, though, unlike most HFpEF patients, his symptoms progressed fairly rapidly, and within a year and a half, he'd had what ended up being Eurocard 3B symptoms. A fairly rapid progression. Given his symptom progression, a repeat echocardiography was done, and it redemonstrated a normal EF and that same LVH.
Paul, did he have hypertension? Excuse me, Paul.
He did, in fact, with hypertension. He'd been on lisinopril 40 milligrams for many, many months. And, he'd also been on Coreg for rate control. But he'd been on effectively 2 agents for his blood pressure.
Do you think it was well controlled?
So the notes we have suggest that it had been well controlled during that period of time. And the decompensation was not due, his worsening symptoms was not due to poorly controlled hypertension.
Do you have his EKG to show us?
I ended up removing. I had a slide on his EKG. The EKG I ended up removing because it was a rate controlled AFib without much in the way of LVH present. It was a fairly normal rate controlled AFib EKG.
Would you say
which
it was
I think is
low
a telling
voltage?
It was actually a normal voltage. One would say maybe inappropriately normal given his LVH.
Thank you.
Just going through the history for him, he'd had increasing diuretic resistances. Diuretic need had gone up quite a bit, requiring a thiazide diuretic intermittently. He'd been hospitalized twice in the past year, and given the fact that he had, decompensation, pre-syncopal symptoms, there was a concern for amyloidosis, and his community cardiologist rightly undertook a cardiac MRI, and that is where we were involved. Just summarizing the rest of his history, there was a remote history of carpal tunnel release surgery bilaterally. He was a former smoker, and family history was notable for a paternal grandfather with sudden cardiac death in his 40s, but otherwise no heart failure, no malignancy, no early or accelerated coronary artery disease. So I will jump to his MRI, which was a diagnostic study. So this is the summary. I'll just have the images for you in just a second. But the important thing is that we have preserved biventricular ejection fraction with a diffuse late gadolinium enhancement suggestive, infiltrative cardiomyopathy, most suggestive actually amyloidosis. So we have an imaging finding concerning for amyloid, and that it is with this finding in hand that he arrived at our clinic. So I will quickly review his imaging. So the pre-contrast study showed a cardiac MRI anomaly that is suggestive of infiltration in increased extracellular volume. Almost prolonged.
Is that Paul? Is that the kind of more orange-red spot in the middle of the ventricle, or is that what?
If you look at the there's a scale on the scale on the left. That's the blood pool itself that has the highest T1 time. But if you look at the myocardium itself, it's that purple, dense purple tissue that's abnormally, that has abnormally prolonged T1 decay. So it's that purple tissue that I didn't have a normal in comparison, but it's that purple tissue that's most striking to me.
Kind of like when you have an echo and you have, the color goes past the ICOS limit and you get this, mosaic pattern. Is that sort of similar to this display in the sense that you have a 2,000 meters per second scale, I guess, 0 to 2,000, and the top of the scale is red?
So it's less a it's not really a velocity of blood like it is the like it is in Doppler cardiography. It's more a decay of the it's more of a tissue decay, the T1 time that we're looking here. It's a little bit exotic. This actually is not even all that diagnostic. It's the late gadolinium, which is the most concerning, that I'll get to in a second.
Okay, yeah, no, I was just trying, because I've heard, when we've gotten MRIs in patients with suspected amyloid, and they say, oh yeah, the blood pool is bright, or whatever they say. I never did quite understand exactly how that was, but so that's all.
The in terms of diagnostic, specificity, it's the T1 is suggestive, but it's the late GAD that's a little bit more, as I understand it, a little bit more specific. And I'll get to that. I'll show a couple images of axial slices in a second.
Thank you.
So this is the four-chamber view on MRI. That's yeah. So that it just redemonstrates very hypertrophy left ventricle by atrial enlargement in short axis. Again, the same pattern of very hypertrophy LV.
Yeah, you can imagine at least visually that it's very stiff.
Mm-hmm.
So there is there's not normal but nearly normal contraction, but you can just see that it is very non-distensible basically.
Mm-hmm. The short axis is provocative, but it's really the four chamber to me that was provocative. The echo, I didn't include the echo images, but it was the same type of thing where I think even a first year fellow hopefully would recognize the significant hypertrophy. The current slices just show this kind of characteristic subendocardial enhancement with late GAD that really caught the eye of our MRI reader and allowed for a kind of a strong findings, not exactly non-invasive diagnosis, but very suggestive findings that our MRI readers have a strong experience with this. This is just the meaningful image from our echo report is the apical sparing that we see, not uncommonly that I'll discuss once we get to the diagnostics, but apical sparing was noted as well.
So the GAD wasn't very bright on the late gadolinium enhancement. It's not very bright there. Perhaps they imaged it a little too late because you have to image kind of early when you're doing amyloid workup. Instead of imaging the usual 10 minutes or something, you have to image a little bit earlier. So maybe they were imaging a little too late.
I don't think when they ordered the MRI, I don't think they specified amyloid. I think they just did a non-specific workup, which is a good point in terms of help guiding your MRI imagers what to look for.
But in the office, given the CMR findings that he presented with in the symptom pattern, we elected to pursue a right heart cath with biopsy. And several days later, he was brought in for that study. If it turned out that his cardiac index was borderline depressed, we'd begin a transplantation discussion. So just running quickly through his stay here, there was evidence of intermittent low blood pressures even during the daytime, 96/54. There were moments of bradycardic ventricular response and some short pauses on tele. His exam was notable for congestion and S4 present.
Good.
And in line with his presentation, his cath showed basically elevated filling pressures and the thick index of 2.1. So he did in fact have borderline index and kind of confirm what we were concerned about. His wedge was 20, RA was 10. Our wedge ratio was 0.5. That all this combined is a concerning finding for us, and we ended up admitting him post-cath for diuresis and planning. His biopsies were pending. Very quickly, his laboratory I'll just hit the high points here. Mild CKD, as stated before, serum free light chain was ordered, and it was minimally positive, 175. BNP was mildly elevated, 347, but he had a normal troponin, and his lactate also listed here was normal. So, given the fact that he had this free light chain ratio mildly positive, we elected to just conservatively work that up, and turns out that his SPAP and immunofixation were both normal fractions. And during his hospital stay at the last laboratory that was meaningful was that he had a biopsy returned positive amyloid. The tissue was sent to Mayo for laser microdissection and genotyping.
Now, so the genotyping, how is that done?
So we use Alnylam, which is one of the drug manufacturers who offers that.
Yeah, because one of the little hang-ups that exists out there is if you send the sample to Mayo and have them tissue type it, they can type it, but they're really probably the world expert on typing between AL and TTR, but they still don't reliably see a mutation when they label it TTR. So you still have to do genotyping, but it sounds like you did, so that's fine.
The genotyping was, it did not demonstrate any mutation, so it was presumed that he was in fact wild type TTR.
Yeah.
Running through the rest of his clinical course, we down titrated his lisinopril, and given his bradycardias, we stopped his Coreg, and he ended up getting a pacemaker ICD, given the fact that he still had pauses off Coreg. The important thing is that we did not pursue the technetium pyrophosphate confirmatory test for TTR while he was inpatient.
Well, you could argue we should have done that before the biopsy, but we already had the biopsy at this point, so there was no additional evidence for pursuing the PYP scan at this point.
Yeah, no, and I would argue differently in the sense that, I know that there are published literature saying how beautiful a PYP scan may be, but I have not found that to be quite as reliable, and I think I would go back in history for 20 years and think, would I have rather made a major decision about a nuclear test versus a cath 20 years ago? And the answer to that, at least in my opinion, is no way. So I think in this situation, fast forward 20 years, that if you're going to make all your decisions based on a nuclear scan, then I think you're making a qualitative mistake.
Yeah, I think that's a good point, and I think it also depends on your clinical context. I mean, if you have an 85-year-old with suspicion for TTR, I think the nuclear scan is probably most appropriate. There are not going to be a lot of treatment options anyways at this point. But certainly in someone who's younger, maybe transplant eligible, to make major decisions, and I think your point is well taken.
Yeah, and then the other question is so if he was in chronic AFib, the dual chamber ICD, what was the atrial lead for?
Yeah, it's a good question. I'll have to go back and see if he was still in AFib when he was with us in the hospital. So I'm not sure if it was chronic or paroxysmal. I'll have to go back and check that.
Yeah, I think but I definitely agree with proceeding with an ICD, because if you're trying to treat this guy aggressively, I mean, he's at super high risk for sudden death.
So ultimately, he was diuresed to dry and was to be seen in clinic post-discharge. And the question ultimately that faces us now with this diagnosis is what's next for our patient. I just wanted to talk very, very quickly through cardiac amyloidosis, a condition that all of us are familiar with. The important and kind of the high points are that it is a common phenotype for several different proteins. Create the same phenotype of amyloid fibrils. There is this beta-pleated sheet that develops from the TTR monomers that disassociate, and unfortunately create this very, very a protofibril that's very, very resistant to proteolysis that ends up depositing in tissues and creating the disease states that we're dealing with here. So, several different proteins can lead to this. Most important from our perspective are light chain, or AL amyloidosis, and transthyretin. The most recent, the newcomer to this list is ALEC2. And depending on the tropism of the amyloid fibrils, you can get nephrotic syndrome, neuropathy, factor 10 deficiency is the hematologic variant or consequence of AL amyloid. And there have been very elegant animal experiments that showed that deposition is related both to the type of amyloid as well, that the mouse or murine model or canine model incubates with the amyloid milieu. So this is a well-studied, well-characterized condition. Dr. Grogan from Mayo has this wonderful, detail about this. But the meaningful thing is that the tetramer dissociates, and these monomers, when they misfold, create this very, very resistant fibril that leads to all the pathology. This is the familiar Congo red staining and the apple green birefringence with polarizing microscopy. And ultimately, these fibrils it's more than just infiltration. There is a direct toxic effect on the cardiac tissue. There is small vesicle ischemia due to local compression. There's a spontaneous thrombosis that's better noted in AL amyloid, but this is not just this is a deposition disease plus. And it's a very interesting condition. So drilling down into TTR amyloid, it's due to prealbumin. It's a form of thyroid. It's synthesized predominantly in the liver, with small fractions manufactured in the choroid plexus and the retina. Carries hormones in the body, and the two types that we'll be dealing with is the mutant TTR, which has point mutations that lead to certain syndromes: familial amyloid, polyneuropathy, and familial amyloid. Very interestingly, different point mutations have widely different penetrance, tropism, and age of onset. And another interesting component is the wild-type TTR, which it doesn't seem like anyone has quite figured out how, in fact, this normal protein misfolds and aggregates. There's some work that suggests it might be a chaperone-related issue. This is just a model of the tetramer, and these two mutations, the VAL30 and the VAL122 point mutations, are examples of the mutant TTR. And interestingly, the arrow is pointing to the bound T4 site, which is actually where tafamidis acts to stabilize the tetramer. I'll be getting to that in a second. There's over 100 known mutations that lead to mutant TTR. They're reliably autosomal dominant in inheritance. There's variable penetrance. For example, the VAL30 MET that causes the FAP has a very, very rare incidence of cardiomyopathy, and endemic VAL30 MET is very little penetrance. Non-endemic is high penetrance for one reason or another, and that's in contradistinction to the 111 MET, mutation that's one cause of FAC. There's polyneuropathy, but a very, very high penetrance, interesting. Drilling down to the American population, the most common mutation among our population is the VAL122 isoleucine point mutation. Represents about 3.5% of the African American population, and using current census data, that there's a suggestion that there could be 1 million VAL122 positive patients walking around currently.
You should point out that the penetrance is certainly incomplete, so not to suggest that there's 1 million patients that are affected by disease, but at least that carry the mutation.
Thank you for that.
Well, I have a feeling that for those of us who are in this space, there may be 1 million patients out there. At least it seems that way. But the thing is that once you start looking for, the genetic mutation and you start finding it, you find it in a single person, and then you have to screen the brothers and the sisters and the children and the parents. And, as you find out, once you start doing that, is that there's a ton of asymptomatic disease or previously undetected disease that's out there. So I think the whole, implication of genetic screening is one thing, but the other part is that in many of these patients that present with some degree of hypertrophy and evidence of heart failure, that you have to put amyloidosis on your list much sooner than we would have done in the past. And for example, if you just are in an echo lab somewhere and you read echoes all day, and 50 or 60 echoes come across your screen, all those that have mild LVH, for the most part, you just blow that off. You just read mild LVH and move on. But the likelihood is that a substantial percentage of those are actually amyloid that wasn't previously detected.
Yeah, and that's where the PYP scan has a lot of value. The studies with patients referred for severe, for TAVR, for severe AS, with a sizable minority of those patients having a positive PYP scan. So very, I think you're right. I think there's more to come.
The wild type TTR patients are so a little bit more complicated. Prevalence is, as Dr. Tranberg just mentioned, is kind of an interesting problem. Importantly, the takeaway is that while it's histologically present in a significant portion of elderly, particularly elderly males, there's a very much smaller proportion actually of clinical disease. But a lot of thought leaders think that this is likely to become the most common cause of cardiac amyloid in the future.
Yeah, well, so it's kind of interesting. This there was a paper that came across my email thing, and it was just published on Valentine's Day in JAMA Cardiology, and it was systolic blood pressure and outcomes in patients with heart failure with preserved EF. And it basically showed that when their blood pressure was low, that their outcomes were much worse. And it's so interesting if you start thinking about that what percentage of those patients actually had amyloidosis?
Yeah, no, it's fascinating, and I think now that we have, even if they're non-invasive, at least to diagnose it. I think now we want to kind of back to our putting it into context. Looking at the prognosis of ATTR and some of the limited staging studies that we have, and looking at transplant outcomes and whether that should be considered. So we'll kind of focus in on that now.
So between mutant and TTR amyloid, there's cohort studies, a lot of observational studies have shown that there's expected 2-year survival about 98% and 5-year in the neighborhood of 75%. I'll just show several current studies out there to demonstrate that. This is a early study from '05 that shows about close to 98% 2-year survival and in the neighborhood of 75% 5-year survival. This was the study that I referenced, 98% at 2 years and 75% at 5. And this is again, like the previous study, showing kind of a very similar survival pattern. This is a more recent study by Penny that again redemonstrates similar survival for the this time predominantly wild type TTR, and there really hasn't been good data that shows a strong difference between mutant and wild type. But just to circle back to our patients, so TTR wild type, it's been alive 1.5 years from the time of symptom onset. His BNP is mildly elevated, 340, moderately elevated, 347. Troponin's negative, his GFR is 73. How do we risk stratify him? Where is he in the process of listing? It's someone we should be more aggressive with, someone we should be less aggressive with. So just running into the talking about staging system. So the first staging system to come about was Dr. Brogan's work. She took 360 patients with biopsy-confirmed TTR. They were all wild type, and looked retrospectively at their risk factors and chose cut points that discriminated best for survival. Found NT-proBNP and troponin were had the strongest correlation with survival, and using these cut points of 3,000 for NT-proBNP and 0.05, patients who had a troponin that was greater than 0.05 and a BNP that was greater than 3,000 had the worst prognosis. And if you look here at the curve, we have a 2-year survival right around 50%. So remarkably different from the stage 1 patient who is neither an elevated troponin nor an elevated BNP. So this really helped stratify that patient population. Unfortunately, though, there was no validation cohort. It was simply a test cohort, and we didn't really have a huge number of patients, 154. The follow-up study to this was done by Dr. Gilmore in England, who looked at 869 patients with TTR. The majority of them were wild type, but there was a meaningful number with several different mutations, Val122 being the dominant one. Again, the same type of regression was done that identified GFR and NT-proBNP, and the similar type of staging system, 3-tier was proposed, and it was tested in a validation cohort afterwards, and I'll get to that in a second. But they used the same cut point of 3,000 for BNP and introduced a GFR of 45. And using this, they found a median survival of 69% for stage 1, 24% for stage 3, and they took their staging system and compared it to a test cohort from a different country, from France, similarly biopsy-proven ATTR, and compared it. And if you look, the hazard ratios comparing survival stage 1 versus stage 2, 2 versus 1, or 3 versus 1, 3 versus 2, etc., had good had good separation between test and validation cohort, and also comparing the Gilmore GFR and NT-proBNP versus the Grogan stage. So it was a confirmation, both of the validation, both of the Gilmore work and of the Grogan staging. So both of them performed quite well. Similar hazard ratios across the data sets. And this is the Gilmore Kaplan-Meier curves. So if you were stage 1, you had a similar survival to what was seen in the previous studies, in the neighborhood of 90% 2-year, 5-year in the neighborhood of 70%. So similar to prior data, but it took the patients who identified the patients who these stages identified patients who do worse and appropriately separated them. So there were fewer patients who were stage 2 and 3, but it appropriately risk stratified those and identified them for clinicians.
So with that in mind, I mean, if you look at our patient, he actually has, if you go by these staging systems, he has pretty good survival. You'd say, 5-year survival, close to 75%. But I think what our argument is that this guy has clinical heart failure. He's New York Heart 3B, elevated wedge, mildly decreased cardiac index, a couple of hospitalizations in the last year. So I think the staging system certainly has limitations, and there's not a lot out there to help guide us in these TTR patients in terms of prognostication. And so with that in mind, one, we want to look at transplant outcomes in this population, which we'll do in a moment, but wanted to hear from you guys what you guys would do for this patient with that in mind.
Yeah, so it's interesting, that the AL staging system is based on cardiac biomarkers and free light chain ratio. That's the AL version. And then they tried to come up with a similar staging system for wild type. And so they used, in one of your staging systems, they used cardiac biomarkers. And the other one, they use one cardiac biomarker and EGFR. And so it's kind of interesting that, the whole measurement of outcome, for the most part, is based on cardiac involvement. And if you're looking at overall outcomes for cardiac involvement and you don't include functional impairment, then, that's how if you think about any heart failure trial, they include, EF measurement or the extent of coronary disease or whatever other parameter, but they also include, NYHA class or some sort of functional assessment, whether it be 6-minute walk or, whatever other test, SVO2. So I think that the idea that you would stratify people solely based on a blood test seems probably not correct.
And the other thought?
Well, and the other thing is, in your patient, so he's 70 years old and he's highly symptomatic from his heart failure, from wild type amyloidosis. So then, and it seems as though predominantly his heart is the most affected organ. So then, you could consider him for transplant, which is probably what you should do, although he's a little bit old. I mean, 70 is probably, I don't know about your process at Methodist, but that's getting up there. And then the biggest determinant for transplant candidacy will be other organs that are affected. So in his case, does he have any orthostasis or peripheral neuropathy or any sort of autonomic dysfunction?
No, he's really free of any other. He had carpal tunnel syndrome a decade prior, which is kind of typical. but no neuropathy, no orthostatic hypotension, and outside of amyloid, really no comorbidities.
Yeah.
Kidney
So
failure, and then he's pretty.
yeah. So I would say that he's appropriate for transplant evaluation, I would think. I mean, again, you guys know your local details better than I do, but that would be something that I would think about. But you also can't wait a long time, because I mean, if he's 70 years old, then he's near the end of his transplant candidacy there. And I would resist all temptation to even think about any kind of durable VAD. That would be a big mistake.
Yeah, no such temptation.
But just for the current time, I would say this is the kind of patient that I would definitely put on diflunisal, because his creatinine is okay. And then hopefully the ATTRACT study, which is tafamidis and TTR amyloid, the data will read out any time now. So they've completed the whole study, and I was hoping that they would present the information at ACC, but I don't think they're going to. But nonetheless, that's a medication that was given in a phase 3 study of patients with cardiac amyloidosis, and it was given versus placebo. So this is a definitive trial, and the data lock happened about a month and a half ago. So they've had a month and a half to grind through all their data. So
yeah, and I think we'll show a brief summary of the trial. And from what I understand, I think it's going to come out in the fall of this year, from what I've heard.
Yeah, I imagine that it would make a lot of sense, since it's an international study, to release the data at ESC, since that would be the biggest international cardiology meeting. So I think that's probably what they're doing. But there are patients that you come up with every single day where it would be really nice if we had a reliable treatment to give them.
Absolutely. And any other thoughts on what anyone would do something differently with this guy, or? So we ended up discussing him, and we actually listed him for transplant. We can have a good debate, which we actually did internally, about heart liver versus heart only. We've predominantly done heart liver for these patients, with the idea that, one, we don't know how quickly the process will accelerate in the immunosuppressed patient to deposit fibrils in a new heart, and two, our liver colleagues have a lot of patients on the alternate waiting list for liver transplant, and we're able to do a domino from the and which is still functionally okay, and give it to a patient that is not going to otherwise get a liver transplant due to cancer or other issues, and give them several years of additional life. But we'll briefly look through the transplant experience and amyloid to wrap up.
Yeah, so I don't know if you tried diflunisal, but I think that might be something that's available that you could use, but it's not going to make a big difference, but it might make a small difference.
Yeah, we elected. We ended up putting him on the transplant list without diflunisal, but we talked about it and decided he's going to be on the list anyways.
So he goes in at status 2, right? Did you get some exception, or?
No, not in the current paradigm. But we have a strategy of watching them closely, and if they decompensate, bridging with axillary balloon pump, so that they can place percutaneously in the cath lab, and allows them to ambulate and not be bedbound while they're waiting. So right now he's status 2 at home, but if he starts worsening and he gets admitted, we'll probably pursue that approach.
Very good.
So is doxycycline still used for treatment for anti-fibrinogenesis?
I mean, I think there's a little bit more data, still not a lot, but a little bit more data in AL amyloid.
Yeah.
So I don't know so much about wild type TTR. That's the problem.
Yeah.
But yeah, I mean, if you're trying to reach for something, then you could consider reaching for that, I would think.
Let's see. Do you think his carpal tunnel syndrome is related to the amyloid? That seemed to be a few years ago, wasn't it?
Yeah, but it's such a I mean, it seems like 100% correlation. When you figure out that somebody has amyloid, they've all had carpal tunnel surgery.
Especially bilateral is really more specific for ATTR, for wild type ATTR. So I think it's undoubtedly connected. It is interesting that there's such a gap of time. So it probably is a more indolent development than what we understand.
Well, in the interest of time, I will skip diagnostics, which we are all familiar with, and proceed straight to treatment. So, as we all know, the goal-directed medical therapy for HFrEF has very little place in the amyloid population. Only spironolactone and diuretics really are tolerated. Quickly, there are options of liver only, heart only, or heart liver combined. And as far as liver transplantation goes, it's really best used early in the course of disease, prior to a cardiomyopathy developing. Mind you that the liver transplantation does not reverse deposition, it halts the progression of disease. And interestingly, there have been numerous news reports now published that shows that the TTR can progress post-transplant due to the choroid plexus and retinal population of cells that produce TTR.
Yeah, I think most of the time liver transplant is reserved for people that have a mutation, right?
Yes.
It seems like it's been used more commonly in the FAP population, the polyneuropathy group, but before they get autonomic dysfunction orthostasis. Just looking through the recent review on transplantation, looking at the heart-only cohorts, 1 year survival, and mind you, these are small studies, ends of anywhere from 5 to 10. Importantly, though, the 1 year survival a little bit less than published goal, 74 to 86%, and this was in a population that included both predominantly mutant, TTR mutant population, and as well looking at the combined heart liver, again, small numbers, and given that the 1 year survival is kind of all over the place, ranging from 66 in a very early study, an early experience to 100% in more recent work. The heart only cohorts. The datum is that an Italian group published recently, the Corredu et al. Paper found a 1 year survival of 93%, a 5 year of 82%. Heart liver, and there was no real differences in between the heart only and the heart liver. One of the benefits of heart liver is that, so for example, there was not a significantly worse survival for the combined, and the combined strategy, if used in a domino format, leads to improved liver availability. The one thing that stands out is the Heidelberg experience. 16 patients, heart only. They discuss it in terms of two eras: a era from 2002 to 7, and then 2008 to 17. That was largely pre-bortezomib and post-bortezomib era for AL. So that is meaningful for TTR, but the 75% 5-year survival in the most recent era. So very good 5-year survival for heart only. The interesting thing as well is that despite the fact that the liver that's producing the aberrant TTR didn't cause any symptoms or any heart failure symptoms or really damaged the allograft over the next 10 years by biopsy or echo. So heart only is a successful strategy. If you look at the breakdown, and using the staging strategy that we discussed earlier, the population studied here, all mutant TTRs were either stage 2 or stage 3, so advanced TTR. And the most recent era 2 of the most recent era is the graph on the right showing a 75% survival that was preserved out to 5 years. And importantly, that the TTR mutant heart-only patients had similar outcomes to other era-matched high urgency candidates. So heart-only is a very potent option for these patients. Looking at our own experience at Methodist, so we've had 5 patients thus far, and only one negative outcome, only one death, so 80% survival all the way out to 5 years. So we've had
no, it's 100%. The one death was at 10 years. So so we've had our 5-year survival is we only have 2 patients that are 5 years out. So the most recent one, 7+ months. So our 5-year survival overall, including the AL amyloid patient, is in excess of 70%, which is not inferior to our general transplant population. So
that's actually quite a big experience. 22 patients, that's a lot.
Yeah, it is a lot, and we thought it was a lot, and we're in the process of writing it up. And the German 56 patients just came out a few weeks ago in Journal Heart and Lung.
That's okay. Don't be discouraged by that.
Yeah, we're still working on getting it out there though. So we've had the experience. We've done out of the 5, all have been heart liver recipients, except the first patient who was diagnosed on an explanted heart, and he's the only one that got a heart only, and he actually survived 10 years. And we've done, out of the other 4, we've done 3 domino livers, so 3 patients were able to get liver transplants on the extended liver waiting list, and 1 had some nodular liver with some early cirrhosis, and so they were not able to take their liver.
No, that's really great.
So our outcomes have been good, and because we've done well with the heart liver experience, I couldn't convince my colleagues to go heart only in the 70-year-old. He's listed for combined heart liver as opposed to just the heart only.
So will you try to do the domino procedure?
Exactly. That's the way to do the domino.
So I'll just jump very quickly to the medical therapy component to this that was discussed earlier. Tafamidis, a small molecule, binds to the TTR molecule and prevents dissociation into monomers, which is meant to stabilize disease progression. It does not reverse deposited fibrils, but the thought is it can be used post-heart only in patients to prevent long-term future deposition. The current placebo-controlled study will read out soon. As discussed earlier, this was the phase 2 that preceded it, published by Matthew Marr. It's an open-label single treatment. Endpoint was TTR stabilization in 6 weeks by a turbidimetric biochemical study. They had 35 biopsy-proven patients. The predominance was wild type. They also had secondary endpoints: New York Heart Class, Kansas City Cardiomyopathy Questionnaire, 6-minute walk, biomarkers, etc.
But the follow-up study was placebo controlled.
Yes,
double-blinded, and that is the one we're expecting to be out soon.
Yeah, I think the bolded line there about does not improve or does not reverse progression. I imagine that's probably not true. At least, my observations of patients that we had in the study, that, the way that the TRACK study was organized is for 30 months you were in a blinded study, and then you go to open label. And so I had a number of patients that went to open label, so they got drug for over a year, and there were clearly people that their disease was progressing, and then when they went to open label, it seemed to stabilize. It seemed fairly obvious to me. And so I think that, of course, we need to see the actual data, but I think that if tafamidis is effective, it will be effective not only at preventing disease progression, but it will help to reverse the process, because you're counting on your body's own ability to handle disruptions. And if you take away the continued onslaught of TTR into the tissues, then your body's own way of dealing with it will take over. So I think that I certainly have high hopes for tafamidis, just because I would love to have something to offer these patients.
God, I hope you're right.
So again, just looking at demographics, predominantly we're broken stage 2, and just as discussed here, the TRACK study that was just discussed a second ago found that there was a untreated progression of disease in 72% of patients over 12 months. And comparing that to the tafamidis phase 2, there was only a 48% progression that was identified. It was pre-specified as death, heart failure, hospitalization, a increase in NT-proBNP or creatinine, or decrease in 6-minute walk time. So, looking at the outcomes of the study, there was a meaningful decrease in progression noted in as little a period as 12 months. And importantly, all but one patient had a TTR stabilization by this turbidimetric study. This is just a kind of running through the data. Again, a small study, but a meaningful result. 25% decrease in progression. And we look forward to the tafamidis phase 3 this summer.
Yeah. So that wraps up our talk.
Super presentation. Great. Thank you guys so much. This is a great study, great example.
Yeah, we appreciate the discussion. Any other thoughts or comments?
Yeah, good luck to your patient there. Hope he gets that phone call.
Absolutely.
That's a very good presentation. I really appreciate the information. That's really super. We'll discuss this with our fellows. Let me ask you, do you have any experience with dialysis-related amyloid on those patients who've been on dialysis over 12 years or so?
Yeah, we have one patient recently that has cardiac amyloid and ends up being secondary AA amyloid and he has Still's disease. So it's and he's on dialysis. So it's a combination of his Still's and autoimmune disease and chronic inflammation plus dialysis. So he has a cardiac amyloid as well. And there's really almost no data on their prognosis compared to other types of amyloid. He's someone we have not. He's young, but with his Still's and his disease that's still not well controlled, we haven't yet, and he's not really been in the hospital. We have not yet agreed to list him for transplant yet. We're watching and waiting, and it's a great question. And I don't know if any of you have an experience. We certainly would love to hear about it because we have one patient here only with that.
Well, we just have this past 2 weeks, we've seen 2 people with AA amyloid. And so I was hoping that you would come up with some bright answer.
Unfortunately.
Because I don't have one. So
have you seen many before? It's just
no, I mean just a handful, but I don't know what to do about it. So I was hoping that you would have the answer.
Wow, I wish I did. But if we get year 2 and R1 and we report that, we might have more than what's in the literature.
Yeah, I don't know. Don't know what to say about it. I think you deal with the heart failure in the best way you can, and then I don't know if there's some inflammatory condition, I guess treat that, whatever that is.
Yeah, I mean that's what we're doing, and if he progresses and has clinical heart failure, and we're able to get a handle on his arthritis, then we may end up looking at transplant. But right now, so far, he hasn't declared himself.
Well, thank you very much.
Really appreciate it.
Great presentation, guys. We really appreciate the in-depth analysis you've done of this, and let's talk some more about DRA in the future when we got some more information on it. Thank you so much, everybody, for attending. We had today, we had Joan Kraft, Jody, Joe Carver, Joshua Mitchell, Sebastian Schmidt came in late, Thelma Rodriguez. Hello, Sebastian. How are you?
How are you?
Good.
Thank you.
Good to have you here today from Poland.
The weather is better in Poland.
I'm glad. It's like 75 right now here in Tampa. You're welcome to come anytime you would like. So feel free to come visit it and talk about some of the cardio orthopedics as well as cardio-oncology.
Great idea.
Joshua, Thelma, Joe, Joan, Daniel, Dana, thanks a lot for coming. We enjoyed your company.
Thank you. Have a great day.
Have a good day.
Thank you so much. Have a great day.
Talk to you later. Bye-bye. Have a great day.
Thanks for having us.
Thank you.
Bye, everybody.
Nice day.
Appreciate you joining us.